you and welcome to our Department of Psychology webinar. As department chair, it's my pleasure to introduce the director of our Psychological Services Center. But before I introduce her, I want to provide you with a bit of background information about our clinic. And I should note that when I say clinic, I mean the Psychological Services Center. The terms are used interchangeably. Sometimes we also refer to it as the PSC. The Psychological Services Center has been in existence for more than 30 years. We started with a relatively humble facility in Townsend Hall in the 1980s. When the department was relocated to our modern new building in 2006, we were able to design the clinic space to meet the needs of our training program, providing a facility that supports clinical training as well as clinical research being conducted by faculty and students in the department. The clinic encompasses approximately 2,500 square feet of space with a waiting area, reception area, 9 rooms for individual assessment and therapy, and 2 large rooms for group interventions, as well as work rooms for student trainees to complete written reports and maintain client files. All treatment rooms are equipped with state-of-the-art recording equipment to facilitate review of sessions by faculty supervisors. The PSC serves 2 important functions for the department. First and foremost, it provides the initial training site for all students in our doctoral training program in clinical psychology. Students are closely supervised during their initial year of clinical assessment and intervention work, laying the groundwork for them to then move on to more advanced and independent training sites during subsequent years in the program. The second important role of the PSC is that of community outreach. All of the clinical services in the PSC are provided free of charge, and our services are made available not only to students, staff, and faculty on campus, but also to community residing adults, many of whom come from underrepresented groups and may have limited insurance as well as financial burdens that limit their ability to pay for clinical services. In this way, the PSC functions both as a training resource and a community resource. It is fully funded by the department and by the College of Arts and Sciences. With that overview of the PSC in mind, I'd like to now turn to introduce our director, Dr. Ann Holmes. Dr. Holmes is actually a graduate of our doctoral program in clinical psychology. As a graduate student at OSU, she received the 2 most prestigious teaching awards available to our graduate students, one from the department and the other from the OSU Graduate School. In addition to being an exceptional teacher, Dr. Holmes has been active in research, co-authoring several papers while she was a graduate student. Dr. Holmes also demonstrated excellent skills as a clinician throughout her years in the program. Following graduation, Dr. Holmes completed postdoctoral training at the University of California at Davis in the area of early psychosis. We then recruited her back to OSU last year to serve as director of the clinic. The department is proud of the work being conducted in the clinic, and we are extremely fortunate to have Dr. Holmes providing outstanding training and supervision of our students. I'll now turn the webinar over to Dr. Holmes to give you an idea of the great work being done here. Thank you.
Thank you so much, Charles, for that introduction. And thank you everyone for joining today. I'm really thrilled to be moderating this panel discussion. And so as Charles mentioned, I'm the director of the Psychological Services Center, or the PSC, and we are a training clinic whose mission is to provide evidence-based treatment while simultaneously training the next generation of clinical psychologists. So the therapists in the PSC are graduate students in OSU's clinical psychology doctoral program. And today we have a panel of students that were selected to include those who have just completed their first year of intensive clinical training, as well as students who have completed more advanced practica experiences. So I'll introduce these students now. I'm first joined by Kate Valerio. Kate is a 3rd year in the program. Welcome, Kate. Next, I'm joined by Aita Coker. Aita is also a 3rd year in the program. Welcome, Aita. I'm also joined by Nicole Arrato. Nicole is a 5th year in the program. Welcome, Nicole.
Hi there.
And last but not least, we have Gina Gerardo joining us. Gina completed her training at OSU and is now beginning her clinical psychology residency. Hi, Gina.
Hello, everyone.
So thank you, panelists, for being here today. And I'd like to really begin this discussion of training mental health professionals by asking you to share your experience about what made you want to work in the mental health field and what led you to choose Ohio State's clinical psychology program.
I can start us out. So I actually completed my undergraduate training at Ohio State University. I'm a Cleveland native, so it wasn't a far stretch from home. And I was undecided when I took my first class in psychology. And that really had me interested in how I could pursue psychology after graduating. And I wound up finding a position at Nationwide Children's Hospital in their research institute, where I worked with several clinical psychologists who really encouraged me and amazed me in the work they were doing, both clinical and research. And so as the next clear step to seek out training. And it was actually the interview that really sealed the deal for me. I cast a wide net thinking I could go anywhere, but wound up staying in Columbus at Ohio State because I was just so drawn to the training I could receive, impressed with the faculty and the facilities, specifically the PSC.
So I personally, a lot of what Gina said, I agree with. I've always been interested and intrigued by the field of psychology. I truly became inspired when I was working on a cancer research team at Yale University. I'm from Connecticut. I found that the team was really focusing on treating the disease, but not helping patients cope with that disease. And so I decided that's what I had to do, and that's what I wanted to do. And I found OSU's program, which has this specific health psychology track and gives me the opportunity to do research and clinical work, specifically in this kind of niche area. And as Gina was saying, the PSC, the Psych Services Center, is really one of the main reasons why I did choose OSU, due to the beautiful facility, the state-of-the-art technology, and above that, including the opportunities to work with these health populations.
I can go next. My background is in cellular molecular neuroscience from Stony Brook University in New York. And I was doing research and just felt a little bit disconnected from what I was doing. Working with rodent models, I really just wanted to help people a little bit more directly. At the time, I found myself working in the psychiatry department there, working with schizophrenia. And I just felt like that was my calling. That fit me so much better. That was really where I wanted to be spending my time. And I took that as an indication that is really what I should be spending my time doing, therefore. So was a little bit new to the field, but did decide to apply to graduate school. And, to echo Gina and Nicole, just the facilities here, the opportunities, the training experience, we're really so phenomenal, just state of the art, everything that we have here, including the PSC, where we just get such great training. We have such wonderful mentors to prepare us for our clinical work.
I could go next. So sort of the first instance where my interest in psychology was piqued was when I read this novel when I was about 14 years old. It was a typical YA novel, but it's kind of a funny story by Ned Vizzini. It's super popular, so I think some of us might recognize it. But it narrated the experiences of this kid with depression who lived in New York, and that's sort of what started my interest in psych. And moving on and moving past that, I sort of bounced around a little bit, and those interests were increased again at this internship I worked at the Cleveland Clinic. So I went to school in Cleveland. I went to John Carroll University, and my experiences working in the Cleveland Clinic in the chronic pain hospital rehabilitation sort of directed my interest towards clinical health psychology. And that's where sort of my interests were laser focused and more specialized. And that's what drew me to OSU, because we have a really good program here and a really solid relationship with the James Hospital. And coming here for the interview and seeing all the facilities, as everyone has said before this, it is state of the art. That's not an exaggeration or a bit of bragging. We have a lot of really nice equipment here, really finished rooms, a very, very relaxed and accepting atmosphere. And that's what sort of sunk me in to actually throw my hat in the hole for OSU.
That's great. I love hearing each of your stories about what got you interested in the field and what led you to Ohio State. So thanks for sharing. So now I was wondering if you could share about the different training experiences that you've had within the PSC so we can get an idea of really the breadth of different training experiences that have been available to you.
So a lot of the clients that I've treated so far have suffered from anxiety or depressive disorders, but really we're not limited within those categories. So including people with social anxiety can be effectively treated at our clinic and have been by most of us, including me. But that's really been kind of the scope of what I've been treating.
Great. And so, yeah, Kate and Ida, you just wrapped up your second year practicum experience. Ida, did you want to add anything to that?
No, I was just going to reaffirm what Kate said. We have a sort of broad spectrum of anxiety and depression related disorders that we see. And yeah, that's that.
And so, as Dr. Emery and Dr. Holmes have said, everybody in our program starts with that second year practicum. We don't see patients our first year as we're being trained and making sure that we have the right foundation. Our second year, we all work in the PSC, seeing a broad range of clients, and then go on to more other practicum. They are maybe internal in the PSC or maybe external in other locations. This year, currently, I have been working in the behavioral medicine practicum. And so that is in the PSC, and we get to benefit from all of the things in the clinic. And we get to see patients who have physical health conditions that are chronic. So I've been working with folks who have everything from end-stage renal disease, chronic pain, lupus, those recovering from open heart surgery. And all of these people are dealing with depressive and anxiety symptoms and that are related to their illness. So that's what we've been doing in behavioral medicine.
And me being the most senior trainee, I have done both the cognitive behavioral therapy clinic a long time ago and the behavioral medicine clinic. And then in addition to those two experiences, I also was able to participate in a mindfulness clinic, which was also housed within the PSC, so used the same facilities. So there we were doing mindfulness-based stress reduction for a variety of clients. Some had anxiety and depressive symptoms, some just adjustment or high levels of stress. And so we had some really great interest. We kind of cast a wide net with who could be invited to that group. It was a group setting. And so that was very interesting. And I want to say all the experiences within the PSC have the great advantage of being able to record our sessions, obviously with the consent of our clients, but that really gives the trainee, at least personally gives me, a really rare opportunity to watch back my sessions and get that detailed feedback from supervisors on moment to moment what's going on in the session. So something that I think is pretty rare in our level of training. And then in addition to those experiences, I was also at Nationwide Children's Hospital. So the same hospital I mentioned earlier, where I worked between undergraduate school and graduate school. So that's peds psychology, where I worked with children and families and sometimes adolescents in a variety of different specialty clinics, including pain, burn management, feeding, and also bowel management. So lots of really interesting cases from a health psych perspective. And then most recently, I was working in the Wexner Medical Center with transplant psychology. So I'm doing the post-op evaluations and brief interventions using cognitive behavioral therapy with people who had just undergone solid organ replacement surgeries. And in addition to that, I also was in, for 1 year, in family medicine through OSU. So that is a primary health clinic, or I'm sorry, yes, primary care provider clinic. And there was a wide breadth of different cases, different in ages. So there were some adolescents and children as well as adults, and just several varying presentations.
That's great. Yeah, you all have had such a wide range of experiences, and it really kind of showcases the scope of what we as clinical psychologists do and kind of the breadth of training that you can get in a clinical psychology program. So this next question is really for Gina and Nicole. You've had the opportunity to take part in the training in the PSC, but then also go out to these external sites and apply what you learned in the PSC to these other places. So how do you think your training in the PSC really prepared you for these more advanced clinical experiences and also for your future career?
So I didn't mention it before, but in between my 2 PSC rotations, I did a year at Women's Behavioral Health, which is housed through OSU's psychiatry department. And so I really truly feel that I was able to succeed in that practicum because of the tools I was given in my first training year at the PSC. Excellent supervisors, the video recording that Gina mentioned, really being able to think back at, I think I did an okay job in that session, but I think there are some things I could have done differently. And I really want my supervisor's direct feedback. So all I have to do is find the time within the video to say, can you help me with minutes 10 through 15, sit down with my supervisor and say, what would you have done differently here? And that's a really, really special training tool that we have in the PSC, using that video recording to really analyze our strengths and weaknesses in real time. I also feel that I was given the foundations of writing therapy notes in a concise and clinical way during my time at the PSC, which is something, sometimes it's a skill that we don't talk about as much or focus on in our conversations, but it is a crucial part of our work doing clinical therapy. So I think all of those skills I am grateful to have because of my training in the PSC.
Yes, I agree with everything Nicole just said. The level of supervision that I received in my first year practicing was invaluable. I never again had the same level of one-on-one time with a supervisor, not at the fault of any supervisor, but because as things become more advanced and you take on more cases, you just don't have that amount of time or the resources to go into such detail, and you end up, I think it also is a skill to be able to know how best to use your time in supervision, which helped because I had so much individual supervision in that first year. Also, we had a lot of group supervision, which is not always the case in every practicum. And I thought that was very helpful to become more open to talking about areas for growth, to become more vulnerable and able to, look at yourself and what you're doing in the session more critically. So those things I think are strengths, and just a great strength in focusing on manualized treatment in that first practicum. Something that, again, I don't think is very common, that you get to try different manualized treatments for depression, for anxiety, for social anxiety disorder. I even was able to work with agoraphobia in that first year. And so these are experiences that certainly I look back on throughout the years in more advanced practica, and could even look back at those manuals I still had.
Yeah, and Gina, I'm so glad you mentioned this idea of manualized treatment, because I really wanted to ask, how you are being trained as clinical scientists. So you're not only learning how to do therapy, but you're also learning how to do research and answer really important research questions. So how do you think your clinical training and experience integrates research and practice? And this question can be for anyone.
I can speak a little bit to that. So part of our training is also, taking a class and learning about the different manualized treatments and learning how to interpret the literature and the research that's been done on them. So taking, a group of researchers complete a study to see like how effective is what we tell therapists to do, does it work? And we really focus on only using the treatments that work and being able to understand the importance of following that manual, because that is what the research has shown is effective. It's not some other version that you think is helpful, but really being able to understand the importance of what is done, why it's done, and how you need to stick with what was written. So yeah, just being able to take what the research has shown works and then being able to actually do that in practice.
Much of the skills and the methods that are discussed within my client sessions are skills and methods that I've used or am currently using in my research. For example, a lot of my clients have trouble relaxing. They feel, that's a part of anxiety. It's a part of lots of different things. So we use progressive muscle relaxation, which is an empirically supported intervention to help folks psychologically and physically with that muscle tension. And actually, I've been testing the efficacy of PMR, progressive muscle relaxation, in my research. That's actually what my master's project and thesis was about, seeing if PMR is an effective intervention for patients with advanced lung cancer. So in that way, the things that I'm doing in my research life, I'm learning how to implement those things in a clinical setting and vice versa. So they're informing each other.
And I just want to add that I think we've all been encouraged to collect and use data to inform our treatment from our first experiences. So really using measures on a weekly basis with clients to track their symptoms and help that inform how we move on with treatment, or also help show clients how they're progressing or if something is not working well.
That's great. So shifting gears a little bit, we know that psychological disorders can impact anyone, regardless of their cultural identity. And at the same time, individuals from certain marginalized communities may be at greater risk for developing psychological disorders. So what type of multicultural training do you receive or did you receive as part of your clinical training?
I think this is a really, really important topic to talk about. Speaking about multiculturalism and treating individuals from, historically underrepresented communities is a huge part of what we do at the PSC. And like we just said earlier, everything we do here is evidence-based, and there is a lot of evidence supporting the use of culturally competent or culturally sensitive methods and culturally sensitive principles in our interventions. And as someone, me myself, I'm Nigerian. I was born and raised in Nigeria, so I'm an immigrant. So technically, every person I see at the PSC comes from a different culture than I do. And a part of a lot of my training that I received from Dr. Holmes, who was my supervisor the past year, is always centered or has this piece of being aware of how a person's culture impacts the way their disorder manifests in their life. Certain cultural standards and cultural expectations often impact people's decision-making skills, how people process certain situations. And part of what we do with CBT at the PSC involves sort of objectively, quote unquote, objectively looking at situations and looking at pros and cons and evidence against our thoughts and evidence that supports our thoughts. And all of that comes wrapped in this cultural blanket that you must always be aware of when speaking to any clients, really.
That's a great point. And I should also add CBT, cognitive behavioral therapy, for anyone that doesn't know that acronym, which is the primary treatment modality that we train our students in.
I would also just want to highlight some of the training, Dr. Holmes, that you've provided for us in our group training over the last year. As Dr. Emery mentioned before, because our services are offered free of charge, we do get a lot of people from different marginalized or underrepresented groups. And a huge focus of our training was, weekly seminars where we discussed what diversity looks like and how it impacts the treatment that we deliver to people. And we've talked about, ethnic, racial, gender differences, gender identity, sexual identity. Really, we've spanned the whole list to just learn, not just what are the different identities, but what does that mean for us as clinicians? How do we best deliver treatment to somebody who may be different than us in different ways? And yeah, that's just been a huge focus of our training over the last year.
Yeah, and do you think that any of you have an example, or could you talk about, how that training has really translated and really prepared you to work with clients with backgrounds that may be very different from your own?
I looked at the numbers just a little bit ago, and I saw that the clients who I'm seeing now, actually 6 out of 9 of them identify as Black or Hispanic. And actually most of them are 60 years old or older. Working in a behavioral medicine clinic, we know that aging and chronic illnesses tend to coincide. So for both of those reasons, I am very different than the people who I'm seeing, and vice versa. This experience has really given me an opportunity to treat and form rapport with people who come from different backgrounds than me and who have different upbringings than me. And I've actually been surprised at my own level of comfort at discussing these things very outright with my clients, discussing, you are a 60-year-old man and you're African-American and we are different, but we can still have all of the things that we want to have when it comes to this session and the treatment that we're doing together. And also, like Aita was saying, my supervisors have really done a good job of keeping these patient therapist differences at the forefront of our discussions in supervision meetings, so that I do have the right language and the right openness to discuss things that might seem a little bit uncomfortable at the beginning.
Thanks, Nicole. I was thinking the same thing about behavioral medicine. And I just wanted to quickly add to that in addition to all of our supervisors being very encouraging of being open and aware of our own biases, there is within the curriculum multicultural training woven throughout every course we're in. And in addition to that, I know we've invited several different speakers through our speaker series to talk about diversity, inclusion, anti-racism. We also have a book club where oftentimes the reading choices do incorporate choices about multiculturalism. And I know we have an anti-racism student group. So all of these things, I feel like I'm taking what I've learned in all of these areas into the session room with me.
Those are all excellent examples. It's really nice to hear each of you highlight all that you've learned in this area of multicultural training. So now I want to shift a little bit to talk a little bit about COVID. So we know that the COVID-19 pandemic has negatively affected many people's mental health and also created some new barriers for people that were already suffering from mental illness. And it's also really changed the way that we deliver mental health care and how we train mental health professionals. So Gina and Nicole, you've been trainees seeing clients both pre-COVID and then during COVID. So how has your clinical training changed or adapted as a result of COVID?
I could ramble for a long time about the way that it felt to transition from in-person services to virtual services while actively seeing clients. So one week, everything was normal. We were meeting in person, and then all of a sudden that was not feasible anymore. And we had to come up with a way to still reach our treatment goals, but without seeing each other in person. We actually had a lot of phone sessions, just talking on the phone within the clinic at first, while the virtual world was still being figured out. Definitely a lot of learning by doing, some trial and error to make sure that we were doing the best that we could in this unprecedented circumstance. So I think that something that we've talked about already today is that the one advantage here is that the accessibility, you know, patients who have trouble with transportation or are physically disabled and can't, you know, it's harder for them to get places. We've actually had a much lower rate of cancellations since moving to the virtual world in our clinic work. But certainly there are many cons. It's harder to read a person if you're not in the same room. You need to do your best with the shoulders up. And also we need to regulate that professional setting. Sometimes folks think that if they can multitask and they can do their therapy session while they're cooking lunch, but we need to do our best to really emulate what we would have in the PSC or any other clinic, even though we are still in separate places.
That's such a great point about, you know, still getting their undivided attention during sessions.
I just wanted to say I had all those same experiences, fewer people canceling because now they just could remember and turn on their phone. But at the same time, that's right, I could get somebody right out of bed. So trying to regulate that. But at the same time, I was very impressed actually with how quickly my clients, my supervisors, all of us could adjust to the new normal of being virtual. And one unexpected pro is that a lot of my older adult clients in behavioral medicine said that they were then using Zoom to stay in touch with more people. So I thought that was really nice.
That's great. And did you notice a difference in kind of the quality of your training as it shifted to being remote, or the quality of your interactions with clients? Or do you think clients really benefited just as much from these telehealth sessions?
I really didn't notice a difference with supervision. I thought all my supervisors were still very prompt, and it was as if we were in person, only we weren't, but otherwise the same. For clients, I actually, I think because of the pandemic, I was noticing that they were a little bit more appreciative of sessions. You know, for some folks, this was the only time that they would see another person the whole day. And so I wouldn't say the quality changed so much as for some clients, they were telling me that they were looking forward to a virtual session, whereas normally they might have been more reluctant or just not shown that level of appreciation.
Another thing to add here is that to be expected, there are some internet problems that pop up, you know, connectivity issues. And something that has been really special for me is that even if there is a problem with Zoom or whichever platform we're using and we can't hear each other, my client and I are not able to hear each other, but we can still see each other. We actually, you know, get creative as necessary. We might speak on the phone on speaker while still using Zoom so that we can record the session for supervision purposes. But my client was he specifically asked me, can we keep Zoom on? Because I want to be able to see your face. It means a lot to do our session as close to in person as possible. So even if it's not working the right way, it was providing some special connection more than what a phone call could do.
It's interesting, and such creative problem solving too with the internet connection issues. Interesting. And Kate and Aita, you've had the unique experience of beginning your clinical training in the midst of COVID. And in fact, Ida, you and I, even though I supervised you for a year, you and I have not met in person yet. So what was it like to start your clinical training during this pandemic?
It was definitely, I can't say it was unusual because I've never seen a client before. So it's kind of hard not having anything to compare it to. And like Gina and Nicole have said, there are a lot of pros and cons to Zoom. But I will say I've had the opportunity to have a lot of heartfelt connections with my clients. I don't think I have lost any of that emotional transfers, emotional connection that I expect between a therapist and a client. Definitely the internet can be a problem. I've had to end some sessions early. I've had to move things over the phone. And there have been some mishaps with screen sharing and things. But I will say it has been a really, really rich experience from what I can say. I've only seen clients over Zoom, and I don't expect it to be any different from what it feels like in person.
Yeah, I can certainly attest to that. You've still really been able to form good working relationships with all of your clients.
I have seen clients initially over Zoom and then did ultimately have some sessions scheduled in person. And so over Zoom, it didn't feel weird. That was my only normal. And so it was really adjusting to a new normal for me to see someone in person. But even when I did see a client in person, we both, of course, were wearing masks. So whether I saw them over Zoom and we lost some body language over Zoom, or in person and we lost some facial expressions, somewhere in there we were losing some form of nonverbal communication. And I know for me, just like making sure that I was being very expressive with whatever, could be seen at the time. And sometimes that could mean being very explicitly verbal about like, I think that is awesome. You can't see me smiling right now, but it's happening. So it will definitely be the strangest for me to see someone in person without a mask. Like that is the one experience that used to be the old normal that I have still not had yet. But just being able to integrate Zoom and then also seeing the clients in person, I do feel prepared for that. But yeah, talking about it as the old normals, still have not yet experienced it.
Yeah, definitely. It'll be a different experience to be unmasked in a room with a client. And, that's a unique experience to have. And do you think, like, can each of you think about any ways that you think COVID has impacted mental health treatment, maybe in ways that, weren't so obvious or that you didn't really anticipate?
One example that I can provide is specifically thinking back on some of the treatments that I've been doing with my folks who have depression. Very often something that we use in our treatment of cognitive behavioral therapy for depression is what's called behavioral activation. So this is where we ask patients to come up with activities that mean something to them, whether they are pleasurable or provide some sort of mastery, some feeling of mastery. These are the types of activities that can actually break the depressive cycle. And in a non-COVID world, that often involves getting together with other people, being in large groups, doing things that we're not able to do these days, or we haven't been able to do for most of the last year. So it really, what COVID has required us trainees to do is get creative and really come up with ways to make behavioral activation COVID friendly, whether that means using Zoom to still have those interpersonal connections and those family and friend gatherings, or whatever else is appropriate for the client, but something that we kind of consider a foundational part of the treatment that we do had to be turned upside down and really seen in a different light. So that's one way that I maybe didn't expect COVID to change our treatment, but it's something that we've had to do, and it's something that has worked fairly well.
Yeah, you had to get real creative. Any other examples that people have of ways that COVID really impacted mental health, or that it came up in your sessions and how you responded to that?
I think COVID has it adds sort of an edge to certain types of mental disorders. Something that's really common, that was common before the pandemic, was this illness-related anxiety or illness-related panic disorder, where people are afraid of contracting an illness, and they sort of change their behaviors to go out of their way to avoid situations that would put them in a position to contract said illness. And with COVID, and especially at the early stages when we really didn't have a lot of information over how it spread or what it meant, how people got it, it did impact one of my clients pretty significantly. And there was a lot of anxiety. So it was sort of like walking on a nice edge, finding a way to validate her feelings without reinforcing her irrational beliefs about the odds of getting sick. So I think that was something, that was a challenge that, I wasn't expecting when I, imagined becoming a therapist before COVID happened. And that's sort of a way that COVID has impacted at least one of my clients so far.
Yeah, a lot of kind of gray area.
I was just going to say, now that you're mentioning it, I do remember having some of those types of conversations with clients early on. And I still think that our foundation in cognitive behavioral therapy perfectly applied to the new, now COVID themed sort of concerns and thoughts and emotions that clients were experiencing.
Yeah. One question that I had earlier when you were talking about the different training experiences you had in the PSC, you mentioned there being supervision, a lot of supervision, and your sessions are recorded and you watch that. What other type of specific like educational tools have your supervisors used to really train you in these evidence-based practices?
We are very fortunate to have access to a library of videos that we get to see the big names in psychology doing cognitive behavioral therapy sessions, mock sessions with patients, and just being able to scroll through this extensive list of videos and click on, I'm having a problem with this type of patient or this type of problem-solving skill, being able to scroll through and click on exactly what I want help on, and seeing that. Sometimes you can hear about a treatment, you can learn about it in a book or talk about it, but really seeing it happen, patient to therapist, back and forth, has been a tool that my supervisors have provided to me and my peers, which has been really helpful. And I have several, I can think of several times that I've been sitting in the therapy room and kind of replaying some of that in my head and trying to emulate it with my own clients until I really get the hang of it. So that's a really valuable tool.
In addition to the library of videos, I know that all students have access to the PSC Share Drive, which has so many different files that are so useful. So assessment tools that I've used with clients, what else? Different manuals for different presentations, as well as de-identified templates of different types of reports. And Nicole mentioned earlier the strength in report writing that the PSC has. I think that was a big part of my learning to write really detailed yet concise reports, was seeing examples on the PSC Share Drive of how would I describe this, or what's the important information that needs to be documented.
Yeah, so lots of good resources within the PSC. And I know also like role playing has been a part of your training as well to kind of help you to prepare to see clients. Great. So I'm noticing the time, and I'd like to shift now to make sure that we have our final 15 minutes allotted for some audience Q&A. So I've seen some questions come through, and some were also submitted prior to this webinar. So the first question that has come in, and this one was submitted prior to the webinar, is please provide insight on the term evidence-based. One hopes that all mental health theories and practices are evidence-based. So does anyone want to answer, what does it mean for a psychological treatment to be evidence-based?
I could talk a little bit about this. So we absolutely would all hope that all mental health treatment is evidence-based. Unfortunately, that is not always the case. So evidence-based, I touched on it a little bit before, but really involves researchers testing out what they think works. So for example, Nicole talked about behavioral activation, like, is that a helpful skill? Does that actually make people feel better? And so you have to have a group of people. Typically you randomly assign one group to try out behavioral activation and the other group doesn't. And then you see which group got better. Evidence-based usually requires a number of groups of researchers to try this out in different settings and different populations to really provide enough support that we feel comfortable that this actually makes people feel better, whether they're suffering from depression or anxiety or whatever it may be. This particular treatment is effective for them. That's not the case with everything. There are treatments that have been shown to really not be effective. Sometimes they can even be harmful, although a lot of them really just at face value just don't do very much. And one of the strengths here at OSU, at the PSC, is that we have a huge focus on evidence-based treatments, manualized treatments, things that we know exactly what it is, we know exactly what's supposed to happen, we know it's supposed to help. And I think teaching us that, Nicole and Gina talked about all the different resources provided towards that really just enhance that goal of we want to provide treatment that works for people that need it.
And part of what is used within evidence-based treatment, the process of proving something to be evidence-based or not, is objective measures to really not just anecdotally say this person is getting better or they seem less depressed, but using the self-report forms and the other objective ways of measuring depressive symptoms, anxiety symptoms, etc., so that we can see change in those symptoms over time. And we, as Gina mentioned earlier, we use those measures in our weekly sessions with our clients so that we can track the change in those symptoms, so that both before something is evidence-based and after it is evidence-based, we're using these objective measures to ensure that things are going in the right direction and that a patient is being helped to the best of our ability.
Those are lovely descriptions. One question that came in, and Nicole, I think you can speak to this, is what types of clients are getting therapy at Women's Behavioral Health? Is that part of the James or Wexner Medical Center? What types of issues or diagnoses do they have?
Yes, I'm sorry that I wasn't as specific as I could have been when I was first introducing this. I got a little excited. Women's Behavioral Health is through the Wexner Medical Center. And I think it is actually housed within the psychiatry department of the Wexner Medical Center. That rotation, that practicum, sees women in the perinatal phase. So they're either currently pregnant or very newly postpartum, and they're having either depression after having the baby or adjustment problems after this huge life change. So typically the diagnoses that we're dealing with fall under the depression and anxiety umbrellas, with some adjustment, some very acute stress, and those women could be from any background, it could be any age within being able to have a baby. So it is a really wide range of women, all within that perinatal environment.
Great. And another quick question, the student or the book club that you mentioned, this is a student book club, is that right?
I actually believe we had a few faculty join us in the last book we read, so not exclusive to students.
That's great. Okay, so another question, this question came in when we were discussing the impact of COVID on mental health treatment. And this person asked if, how COVID affected some of your patients who had a diagnosis of OCD. So I don't know if any of you had that experience in this past year.
I actually had a patient with OCD, and our COVID didn't directly impact OCD, specifically referring to sort of the fear for illness or the fear of contracting illness, but it did sort of interfere with some goals that I had for this patient, which was becoming more social, going out to meet people, and of course that's difficult when people are advised to stay away from each other. So that's a way that COVID sort of impacted that. Like we said earlier, we just had to find new creative ways of going around that. So our way was sort of engaging in more social media or book clubs on Facebook groups, things like that. And that's just one of the ways that sort of COVID or the pandemic has forced us to think outside of the box when dealing with certain issues.
Great. This another question that came in: are there certain variants, or I guess maybe types of cognitive behavioral therapy? So if we think about cognitive behavioral therapy as encompassing a number of different techniques and interventions, are there certain variants of CBT that you all have found to be most efficacious with your specific client population? And if so, which variants or types or techniques have those been?
One thing that I think has been helpful with kind of the different client populations is really getting an idea of who is the client, what's going on with them. CBT has been tailored and adapted to a lot of different things. But really understanding, what's going on with your client, what might be maintaining the different symptoms that they're experiencing. And so I will say that for certain clients who maybe are just having some more cognitive distortions, it's really the thoughts that are going on in their head that seem to be the most problematic for them. I might focus on the cognitive part of cognitive behavioral therapy. Whereas for some other people, that's just not as critical. It's not as central to what's going on for them. Maybe not specific variants, but just getting an idea of, who is the client and what would be the most helpful for their specific symptoms for them as a person.
Another kind of subfield within CBT is what we call motivational interviewing, which we could consider a variant of CBT. A lot of folks who are working from home, who are dealing with depression, have a lot of trouble getting up and doing the things that they want to do or have to do. And what motivational interviewing involves is really working with the patient to help them realize that they do want this and they do want to reach their goals, and helping them realize why they want those things, and really using some specific skills to motivate them and to get them going. So that has been particularly important during COVID, and certainly a part of CBT that has come in handy.
That's great. Those are wonderful examples. Another question, this is a great question. You all highlighted how the facilities at the PSC are really state of the art and great facilities. So what do you think is unique or more advanced about our state of the art facilities or technology? Could you be specific?
Something that's unique, but not to do with the technology. We've already discussed the recording. To me, that's like the most valuable thing, is being able to record your sessions. But when I went interviewing at other places, and when I've seen other similar college psych centers, frankly, none of them are as beautiful as the PSC. Ida mentioned how calm and inviting the atmosphere is, and that's really true. With each room having a window, that is actually hard to come by in my experience. Very comfortable seating, well spaced so that you can be comfortable with the client, and also like noise machines, just lots of those little things that I think come across as this is a valued space. This PSC is the university values what we're doing.
And just to be extremely descriptive of what this recording is, each therapy room has 2 cameras in there. So there's one camera facing the chair that the clinician is sitting in, and there's one camera facing the patient. And so before the client comes in, we go to one of the separate rooms, we hit the record button, and that records the audio and visual data. And so you're actually able to move the cameras around on, digitally. You can just click the little button and the cameras move, so you can be, you can adjust based on the person who you're seeing or what the room looks like. And then at the end of the session, we go back to that same room, we hit stop recording, we go into the computer area, and we're able to open up a link that has the whole session recorded. You can watch it in real time. You can watch it a little bit sped up if you need to kind of keep an eye on the clock and see all of the parts without the pauses, etc. And also, like I said, there's the camera facing the student and the client, and that shows in a panel, side by side, so you can see everything in real time. You don't have to switch back and forth between the two. So very serious technology, and it's really, we're grateful for it.
Thanks, Nicole, for that detail. Something else I forgot to mention is that all happens, that all is recorded and then saved very quickly, so you don't have to wait around, onto our secure server, which then all of our supervisors have access to from their offices. So no CD-ROMs or other recording devices needed. It's very convenient and secure.
That's really important to highlight, Gina. I'm glad you mentioned that it's all saved securely on the drive in a way that both the trainee and the supervisor can access. And I'm not sure if you mentioned this, Nicole, that the cameras are really unobtrusive. I think that's one thing that's unique. It's a lot of training sites might just have, a tripod with a video recorder there, but you can imagine that might get in the way. You're constantly being reminded that you're being recorded, whereas this is just really unobtrusive. Great. Well, I'm noticing the time. This was a lovely discussion. As we wrap up, are there any final words that, or, anything that each of you would like to say before we all sign off?
Just really grateful for the opportunity to be here and talk about the things that mean so much to us. As trainees in this program, we dedicate 5 to 7 years to this, and it means a lot to know that we are in good hands with our supervisors and our environment. And so I can wholeheartedly say that I feel I'm in the right place, and that is not something everybody can say. So very grateful.
Yes, thank you everyone for your time and interest.
Great. Yeah, thank you all. Thank you to our panelists for sharing your insight and experiences. And thank you to all of our audience members for spending time with us today. We hope that you're walking away from here with a better idea of how we train this next generation of mental health professionals. Thank you all.